I arrived in San Francisco about 15 years ago to start a postdoctoral fellowship at the Center for AIDS Prevention Studies here at UCSF. I came with a shiny new PhD in my back pocket, and I actually also came with a lot of disquieting questions that arose during my predoctoral and doctoral work. My master's thesis was in regard to access to antiretroviral therapy among incarcerated women. My doctoral thesis was on HIV and tuberculosis prevention among injection drug users. These projects had a lot of overlapping issues. Central among them was poverty. What made poverty and health so disquieting for me were the very broad strokes at that time that were used to describe the problems and the solutions. Poverty is a big topic. If we accept that poverty is a risk factor at the heart of poor health for many people, but we don't have any more information or any more distinguishing characteristics about which aspects of poverty are having the most influence or when they're most critical, we can't effectively improve healthcare. What I found in those early years of research was that the context of poverty is where the risks lie. Yet very few studies at that time were really focusing on issues that were specific to impoverished populations. Instead, research that was conducted in the general population was often applied to impoverished people. So I showed up to UCSF, and I found a group of researchers who were some of the very few, not only at UCSF, but in the entire country, that were studying the intersection between poverty and HIV. These investigators were considering disease progression in HIV. They were considering resistance to medication. They were considering changes in biomarkers over time. What I brought to this group as an epidemiologist was a dedication in bridging this kind of research with social and behavioral research. I was interested in digging a little bit deeper. So together with this group, we decided to develop some studies under the general category of what's called community-based research. In community-based research, you don't wait for patients to come to you in a clinic or hospital, and you don't rely solely on medical chart reviews for your research, because there's a lot of people in the community who never make it to the clinic and who aren't in those charts. Instead, you go out into the community, you connect with people in the community, some who are in healthcare and some who are not in healthcare, and you develop a more realistic understanding of health in that community and to barriers to care in that community. For us, this meant starting our research in homeless shelters and in street encampments and in free meal programs in the Tenderloin. It's an intensive kind of research. It requires a lot more outreach and a lot more follow-up than traditional kinds of research. It also requires a lot of contingency plans, because when you're out doing research on the street, nothing ever goes the way you think it's going to go. Yeah. The benefit is that it offers a realistic understanding of health. And perhaps more importantly, it offers a realistic understanding of the context in which health changes over time. I'm interested in this context and how health changes, so I and my colleagues can help to develop effective prevention measures that people can use in their everyday lives and that clinicians can use in their everyday practice. Thinking about this idea of a clinician's everyday practice, my colleagues and I have been thinking about this a lot, and in a recent study, we really addressed this. We recruited 300 HIV-positive, homeless, and unstably housed adults, and we followed them for 3 years. We collected information on clinical outcomes, biomarkers, social and behavioral factors, and we did this every 3 months. We did this so that we could look at which of these predictors were the most important in influencing future health. We used a special type of analysis that allowed us to combine both clinical and behavioral data in the same model. We estimated causal associations between risk factors and health, and we were able to rank those risk factors according to how much influence they had on future health status. Angie, if you could put the slide up, that'd be great, thanks. Among the 25 risk factors that we started off with, those that ended up being the most consistently strong in predicting future health are shown here. As you can see, some traditional factors like adherence to antiretroviral medication and viral load were among the most important in influencing future health. But it was unmet subsistence needs that had the strongest influence on future health. Our results suggest that addressing a patient's housing, food, clothing, and hygiene needs first, even before medications, would have the strongest impact on their future health. This is powerful. We're in an era where ending the AIDS epidemic in the next 15 years is being talked about as a reality. But our results suggest that these breakthroughs and these advances in biomedical research are not going to be fully realized or appreciated by homeless and unstably housed patients until their basic subsistence needs are met first. So in answer to my clinical colleagues who ask, what should I address first when these homeless patients come in and they have so many problems and so many comorbidities? I can say, using empirical evidence, that if you address a patient's subsistence needs first, you're going to be able to better address their clinical issues next. So in closing, I'd like to acknowledge how fortunate I am to do this kind of research at UCSF. Not every institution supports health disparities research with homeless patients. It's messy. It doesn't often make the front page of the New York Times. It can be politically sensitive, and some institutions just don't touch it. I have the privilege of translating this kind of research into usable information that we can take and improve healthcare with. And I do it in a supportive environment here at UCSF. This is one type of research in a much larger toolbox of methods that we can use to improve health, and some of which you're going to be hearing about today. I'm honored to be telling you about this, so thank you for listening, and I hope you enjoy the rest of your discovery talks.